Welcome back, everyone. Today on Health Code Blueprint, we're diving into Chapter 4 of the ICD 10cm guidelines, focusing on endocrine, nutritional, and metabolic diseases, specifically diabetes and obesity coding. This session is all about accuracy, compliance, and risk mitigation. By the end, you'll feel more confident identifying the right combination codes, sequencing them correctly, and avoiding the most common pitfalls that lead to denials or audit findings. Quick disclosure before we start. This presentation is for educational purposes only. It's not legal, billing, or compliance advice. Always follow official ICD 10cm guidelines, payer rules, and your organization's policies. Alright, let's jump in. Let's start with the foundation of diabetes coding, combination codes. These codes capture three things in one: the type of diabetes, the body system involved, and the specific complication. For example, E11.22 tells us the patient has type 2 diabetes with chronic kidney disease. You would then add an additional code to show the stage of the CKD, such as stage 3. And remember, use as many codes within the diabetes category as needed to capture all documented complications and always sequence them based on the reason for the encounter. Next, let's take a look at how we determine the type of diabetes. This part is simple but absolutely critical. The provider must document the type, and we code exactly what they say. No assumptions, no guessing. Here are the key points coders need to keep in mind. First, type 1 diabetes falls under category E10. And remember, even though type 1 is often associated with younger patients, age alone does not determine the type. We always follow the documentation. Then we have pre-symptomatic type 1 diabetes, which is coded from E10A. These codes are used when the patient is in the early autoimmune stage before symptoms develop. So, if the provider documents pre-symptomatic or early-stage autoimmune diabetes, that's your cue to look at E10A. Next is type 2 diabetes in remission, coded from E11A. The provider must clearly document the phrase, in remission. Terms like resolved or history of don't qualify, so if the wording is unclear, that's a perfect moment for a provider query. And finally, one of the most important rules in diabetes coding: if the provider doesn't document the type at all, the default is type 2 diabetes, coded under E11. This rule saves coders every day when documentation is incomplete. Now let's shift into medication management, because this is where our Z79 codes come into play. We use Z79 codes to show long-term, current use of diabetes medications. These codes help paint a clear picture of how the patient's diabetes is being managed. They apply to long-term therapy with insulin, oral hypoglycemics, injectable non-insulin medications. Let's walk through a few quick combinations coders see all the time. If the patient is on oral meds and insulin, you'll assign Z79.84 and Z79.4. If they're using insulin plus an injectable non-insulin medication, you'll capture Z79.4 and Z79.85. And if they're on oral meds plus an injectable non-insulin, that combination is Z79.84 and Z79.85. And here's the golden rule you never want to forget: do not assign Z79.4 if insulin is only being used temporarily during an encounter. Temporary insulin does not count as long-term use. Now we shift into secondary diabetes, which is a completely different category from type 1 and type 2. Secondary diabetes is always caused by another condition or event, something that directly affects insulin production or the body's ability to use insulin. Think of conditions like cystic fibrosis, pancreatic cancer, pancreatectomy, drug-induced hyperglycemia, or even poisoning. All of these fall under the secondary diabetes categories E08, E09, and E13. Let's walk through a common example: post-pancreatectomy diabetes, diabetes that develops after the pancreas has been removed. For these patients, the coding sequence looks like this. First, E89.1, post-procedural hypoinsulinemia. Second, E13, other specified diabetes mellitus. Third, Z90.41, acquired absence of pancreas. And just like with primary diabetes, the Z79 long-term medication codes still apply if the patient is on ongoing therapy. Now let's talk about a scenario that always gets coders double-checking their sequencing: insulin pump malfunction. The first listed code is always from T85.6, because the encounter is due to a mechanical complication of the pump. From there, the path splits depending on whether the malfunction caused an underdose or overdose. When coding insulin pump malfunctions, the sequencing changes depending on whether the patient experienced an underdose or an overdose of insulin. For underdose scenario. First, T85.6, mechanical complication of the insulin pump. Second, T38.3x6, underdosing of insulin. Third, assign the appropriate diabetes code and capture any complications caused by the underdose. Next, the overdose scenario. We start with T85.6, mechanical complication of the insulin pump. Second, T38.3x, accidental poisoning by insulin. Third, assign the correct diabetes code along with any complications resulting from the overdose. This is one of those coding situations where sequencing is critical for accuracy and compliance. Now we shift gears into obesity coding. The E66 category covers overweight, obesity, drug-induced obesity, E66.1, morbid obesity with alveolar hypoventilation, E66.2. And don't forget, obesity-related codes also appear in other chapters, like E88.82, obesity due to MC4R pathway disruption. O99.21, obesity complicating pregnancy. When it comes to obesity class codes, two things must be true. First, the code must include a fifth character to show severity. Second, the provider must document the obesity class. Coders cannot assign the obesity class based on BMI alone. And here's the hierarchy rule. If both Class 3 obesity and morbid obesity are documented, we code only Class 3 because it's more specific. Let's finish with a few key takeaways to keep top of mind. When the type of diabetes isn't documented, default to E11 for type 2 diabetes. Always assign the appropriate Z79 codes when the patient is on long-term diabetes medications. For insulin pump malfunctions, your sequence should include T85.6, the correct T38.3x code, and then the appropriate diabetes diagnosis code. And for obesity coding, remember that class codes can only be assigned when the provider documents the obesity class. Following these rules helps maintain coding accuracy, reduces audit risk, and supports clean, compliant claims. And that brings us to the end of today's session. Diabetes and obesity coding can feel complex, but once you understand the structure, combination codes, sequencing rules, and documentation requirements, everything starts to click. Thanks for joining me on Health Code Blueprint. Let's keep building your coding confidence one guideline at a time. I'll see you in the next video.